Hi, everybody. Welcome to another session of Orthopod. Today, we're in conversation with Dr. Harsha Shanthanna, who is the Associate Chair of Research and Associate Professor in the Department of Anesthesia at McMaster University. Harsha, thank you very much for joining us this morning.
Thank you so much, Mo.
So, Harsha, you've done some very interesting work and you've led some interesting international work, and I'm going to let you go ahead and explain it. But fundamentally, you have been looking at COVID-19 guidance for pain management and specifically providing some specific important best practices based on evidence. And I wonder if you could kind of share that with us and give us a synopsis of what it is you found and what are some of the key findings.
Yes, thank you. What has happened is COVID, as we know, has changed the entire situation around the world very dramatically. And the need of the hour is changing almost every hour or every day. And chronic pain population are substantial in many parts of the world. And they have their own challenges, frustrations, and they're actually very complicated patients because they have multiple comorbidities. Most of them are elderly, and they need someone to really take them out or do something, even for activity-wise. And what we realized was that there is no guidance on physicians who care for these patients, and it was essential that we give some directions or suggestions as to how physicians can handle these patients and continue their care for these patients. So it started off with actually a interestingly a Twitter chat with the upcoming ASRA president Samir Noroz, who is the other senior author in the team at the end. And then it led into a sort of interesting discussion from different experts around the world, where we thought, you know what, we have to really come together and make this a document that comes out and provides guidance. So it started from that. And if you show the paper there, I think it will highlight that we have representation from different parts of the world. And we came together to kind of see what are the main themes or challenges that go with this population of patients. And we've kind of dwelled on the important themes, such as what makes them susceptible, what could be the challenges, such as how do you manage opioids, what are the recommendations on anti-inflammatories, which was kind of all over, and similarly also procedures, which we highlight in this document.
Superb. So, and your key findings then were?
So the key findings were that presently we don't have a guidance, and this was needed to fill that gap. So starting from there, we went into literature to see if previous SARS epidemic or pandemic had any sort of information for us to apply it in this situation. And again, unfortunately, we didn't find a guidance document, but there were some important information which we could put together to inform practice now. For example, as we all know, the contagiousness of this virus is huge. It really is very infectious, but it is in terms of fatality rate, it's high with elderly and patients with comorbidity. And it's important that we highlight with this chronic pain population because they tend to have all these features. And moreover, they are on opioids, and opioids in particular have a particular effect on immunosuppression, especially when taken on long term. So they're more susceptible in that way. And in addition, many of them get steroid injections. For example, in the SARS epidemic, it was found that patients who have steroid injections to their knee joints are more susceptible for influenza. That was a very important point we highlighted. And secondly, many patients still could be on either oral or systemic steroids in this population. For example, maybe generalized arthritis such as rheumatoid arthritis or even simple injections. For them, it is important to note that during the SARS epidemic, there were significant population which are affected by osteoporosis and osteonecrosis of hip joints, for example, because of increased steroid therapy in an effect to counter the virus effects or pathological effects. And I think at this point in time, we really don't know what are the effects of steroids with regards to COVID population, although COVID is supposed to cause hyperimmune effects in one of its sort of pathological entities.
So let
So
me ask you this. Let me ask you one question, if I could just interject. One issue we're seeing, Harsha, is that most elective procedures are being canceled, or let's say canceled for the but held off, right? So we're trying to minimize any sort of exposure to patients, especially in the hospital environment. So let's say for chronic pain treatments that many orthopedic surgeons, many physiotherapists in our group, in our network are dealing with, non-operative treatment becomes paramount. For knee arthritis, intra-articular injections are very, very common. Is there any guidance based on what you're saying? I mean, steroid injections are very common, HA injections are very common, and people are doing all kinds of other PRP injections, have been. Would this guidance, would this provide broad guidance for what should be happening in that population of patients? Should they be receiving injections? Should they not be? Should we be concerned about the steroid in the knee as being a possible propagator of even more challenges for that patient, for immune system? I mean, I'm just going to get a sense from you to bring it to the orthopedic population if possible.
yes, I think it is very relevant now. Thank you. Now, first of all, we emphasize that telemedicine takes an important part in care in this scenario. So we start with call the patient so that you have continuity, and establish whether there is a need for an in-person visit, and avoid as much as possible if that need not be done. And in extreme situations, we do highlight some emergency procedures. Of course, I think knee joint injection may not come in that. For example, the urgent or intrathecal back open refills. But talking specific to, say, a procedure such as knee injection, which could still be very helpful for a patient even to move around the house, we suggest minimize the time you spend with the patient, if at all you're still able to do it. So, for example, at our setting, what we're doing or what we're planning to do next week is we are having a very short injection day, procedure day, and we are calling patients, have them sit in their car in the parking lot, establish everything, including how are you today, what are you going to do, and this is what we're going to do. They come in for 5 minutes just to get the procedure and go back home. And just highlighting some important aspects from literature about the choice of medication. In a very recent randomized controlled trial, it was shown that dexamethasone has a less duration of immunosuppressant effect when compared to methylprednisone. And typically people use pomedrol because it got a depot preparation, but I think it's better to choose dexamethasone and the shortest or smallest dose possible.
Oh, fascinating. Okay, I'll let you continue on because I know you were providing more guidance, but I just wanted to raise that point because I know for many practicing physicians, managing arthritis often comes from non-operative treatments, but also brings in the issue of injectables, and that's extremely sage advice. Thank you.
Yes, thank you. So that is what we emphasize, and I think there's also a question of how about this biopsychosocial management, because what happens in this scenario is pain gets exacerbated, not because there is an actual surge of pain stimulus, but also because pain goes with depression, pain goes with isolation, pain goes with suffering and frustration of I can't do anything. So this is happening right now in many houses because they live on their own and they can't go out, they're socially isolated. So what we're trying to emphasize also, the aspect is there are telehealth programs which allow you to do multiple physicians talking to patients and emphasizing on healthy lifestyle, exercise as much as possible, and even yoga or other biopsychosocial modalities, which will on their own can increase the level of functioning to the patient, even if the pain does not come down significantly. I think that is very important because we want to also limit patients going back to opioids, which people use for various things, including depression.
Would you say that given the fact that we have been somewhat, I would say, as a community, and certainly nationally, if not internationally, forced into this concept of virtual meeting status, do you think that it has in some ways helped you manage patients? You brought up a very important issue, which I think we aren't addressing enough, is sort of the interdisciplinary care for patients at the same time. It seems to me much more facile to be able to have multiple specialties as we're talking together with the patient on a screen and being able to give real-time information. That should be happening face to face, but we don't see that in the same magnitude. And it seems to me opportunities with this platform and this approach may in fact lead us to do more things that way. How have you found this whole virtual conferencing or telehealth as advantage, disadvantage, or where do you see its strengths?
Yes, so the challenges before were a little kind of different perspectives. One was the aspect of, I've never got trained. What are the logistics? I can't see the patient.
Right.
I think what has happened now is this whole scenario has pushed the healthcare to, what, you have to provide it. You can't wait for tomorrow, you can't wait for a month. So it is happening right now. So it has opened up opportunities for many telehealth programs or startups to actually give out their products, and physicians can actually trial, use, and the hospitals will have to make a decision in day or hours to use that. So the logistical questioning is kind of experimentation, but also gives you that ability to experiment and say, what, I didn't really know this, I could do it. So that is one aspect of it. And the second aspect of it is the patient acceptance. And even for patients, there is a lot of positive things that come with televisits. They don't have to drive, the parking charges, the traffic. So as long, even studies have shown that for many, many health reasons, patients, when introduced to that, they would say, what, I would prefer rather to do this rather than come and meet you, because I might be exposed to so many things, or I don't want to drive, I can't pay the parking charges. So the third aspect is the billing provisions. Now, it was very good that the realization set in and they had to open up, not restrict to, for example, video conferencing alone. So that has opened up for all sorts of, just call, you can still bill. So physicians or health providers were naturally concerned whether, if I do it, the delivery of healthcare, whether I'll be compensated. And because of these provisions, I think some of those questions are addressed. So definitely there is a lot of opportunity to engage, learn for physicians. And simultaneously, I was speaking to for example, the Astra group, and they were saying, how about trainees? I mean, we are not being able to train the trainees. And I said, even this use of telehealth, I don't think they have a module on telehealth in pain. And this is it. This is a time where they will learn that, actually utilize that.
So from your perspective, how impacted has the practice of most specialists who are managing pain as one of their priorities been? So have they been able to flip very quickly to telehealth, or obviously so much of the interactions are face to face, and I see what you've discussed as having these very focused clinics that are very carefully organized. That isn't the norm right now. So I would imagine what's been happening in the pain field with respect to getting patients seen, and how efficient has it been for you?
I think, although I just mentioned about all the positives of telehealth, the challenges are how do you select those patients? Because not all patients can engage. And some of these platforms have their own requirements, such as someone has to have an email, or it has to be secure, or so these constraints require that we triage, we go through the list, and you need also the personnel to do that, and that can be challenging. I think right now it is very difficult to know how much has been the impact of this all over, in terms of how many were cared or how many were unable to be cared. But I'm sure it will come out in numbers in soon. But I think at this point in time, everybody is just opening up to the reality that it's not going to be just 1 month. It could be 2 months or 4 months, or
Right.
So
Right. Is there anything else you'd like to share with the Ortho Evidence membership audience worldwide around these particular guidelines. Is there any key message you want to share with us as one of our final statements?
Yes. So as I said, in the document that we provided, we had a few themes that we thought were important. So one was the aspect of opioid and continuity. So it is very essential that if you have a patient on opioids, that they are spoken to and asked about whether they need prescription refills, or if they do need, the reason is when we know about the opioid crisis, and even in this background, we don't want to go back into the situation, and that is still existing. Not that we need to go back. The problem can be that without evaluation, because you can still order by phone, the pharmacist gives it, we have to still be skeptical about their uses and try to minimize that and try to convince the patient that you can still consider other modalities, but still continue with your prescriptions, because opioid withdrawal is very dangerous. And the second aspect is patients, if you don't see them, what will happen is they'll go on to flood the ER, and
Yep.
which is what hospitals don't want. And the third aspect is about use of anti-inflammatories. Now, there's been a lot of discussions, and people have got mixed messages about what anti-inflammatories do in COVID-19, because
Right.
was that AC inhibitors and anti-inflammatories go through the same pathway, and
Right.
they can worsen the COVID physiology in a patient. But right now, there's no evidence. And what we suggest is, because in a substantial number of chronic pain patients, anti-inflammatories can be helpful, it is important for them to continue. Whereas if you want to put someone on a new anti-inflammatory, even by phone, you got to tell them that be cautious, your fever or other symptoms can be suppressed, which could be because of COVID. And that message is key. And I think we talk about procedures. There are some urgent procedures, and I am not sure if someone in the audience has patients on that nature. For example, intrathecal baclofen refills. We do provide clear guidance about what to do. We are coming out with more guidance on how drug concentration can be changed so that you can postpone a refill. For example, baclofen, or some patients in the United States have other medications, so you can consider how to deal with those patients. So I think that clearly gives the message, and we hope to change as things develop within the guidance statement, so it'll be real time and physicians can adapt to it as well.
Listen, on that note, I can't thank you enough, Harsha, for continuing to provide evidence when we're seeing so much noise in the system. And I think evidence-based practice ultimately is going to be what's going to prevail. And getting your message out to as many people as possible, I think, is very, very important. So thank you again for spending this morning with us.
I'm so thankful for you, Mo, and as always, I'm thankful for the audience, and I hope everyone is staying safe, healthy, and it's a very fluid situation, so keep yourself and your family healthy. Thank you.
Great. Thank you so much.